picking up the phone and talking to the consultant concerning that specific problem is taking care of that patient. Um, there's times where I would come in the morning and somebody would be sick as hell, and they go, we put in a cardiology consult, and did you pick up the phone and talk to the cardiologist? No. You know, or somebody's septic and you know, put in an ID consult and nobody's picked up the phone and spoken to the ID consultant. The other thing that's important about critical care medicine and taking care of critically ill patients is that you have to practice shotgun medicine with a lot of bullets. You know, so your job when you take care of the people that are critically ill is to assume the worst and assume that they have a problem that can easily kill them and address that problem. So the person that comes in with a bad pneumonia, hit them with a bunch of antibiotics and don't really care at that point what the ID people may think of you. You know, people that are hypotensive and you have to put a lot of pressures on board. If you have to do it, do it. Don't worry about what people are going to think, but talk to people. Really always assume the worst case scenario when you're taking care of patients and treat them in that manner. And it's especially important in critically ill patients. Because if you miss that one thing, you know, that's a potential death. And you're much better off in your career making sins of commission rather than sins of omission. You know, the things that I regret in my life and in my practice are the sins of omission. Never be afraid to act if you think you're doing it in the best interest of the patient. That's a difficult thing to do sometimes, and you will find that in your career. But if you act and fail, it's better than not have acted and failing by a great degree. I mean, you have no idea that if you have any conscience as a physician, you will really learn to understand that. Because these are decisions that you are going to live with for the rest of your lives if you take this seriously. I mean, I can't impart that to you to the degree I would like to. But I can tell you that every decision I've made in the care of patients, it sticks with you. You know, you got to live with what you do. And that's not really an easy thing to do when you're practicing medicine. It's a really difficult thing to do. Because we've all had patients that have not done well, that you think you may have been able to do better by. So you really have to put everything into it, lay it all out on the table, unconditionally, and let the chips fall where they may, but never be fearful enough that it keeps you from acting in the interest of a patient, because you're worried about what people may think or what the outcome may be. You know, so the other thing with critical care medicine is you try something, and if it doesn't work, then you try something else. You know, it's just the way it is. I mean, that's just like a general introduction. There was one other thing that I wanted to speak about that escaped me. I'm sure it'll wake me up at 2 o'clock in the morning, as most things do that I can't remember. But, you know, what we'll do after this is we'll get into specific things. Like I think the next chapter is airway. And then there's a real great chapter on ventilation. And there's a good chapter on acid base, and there's a good chapter on just about everything. That'll be, I think, quite helpful for everyone. And we can get a little bit more into acid base anyway.
Sounds good.
Yeah. But I think this should be fun. I know Roy's over there. I'm sure he has his own perspectives as well.
About just the general ICU stuff?
Yeah.
Yeah.
And anything you want to add?
Yeah, I mean, I think, when you go through the ICU, you'll kind of appreciate this, but always never forget, why the person's in the ICU in the first place. There's a lot of things that can happen to you in the ICU. They come in for A, and then B, C, D, through H happens to them. And, when you're critically ill, multi-system organ failure is what we do. So you try not to forget what the initial cause of the critical illness is or why someone initially got intubated for. Okay, I think that kind of falls through the cracks a little bit. And then, I think the rest of it just kind of learn at the bedside a little bit. And
I think the other point that you're sort of making too is that you can't box yourself into single thought processes. You can't go into a patient's room and have a preconceived diagnosis, because you can make clinical circumstances fit into a diagnosis, and then you're going to miss things. And we all do that. And sometimes what's good, especially now that there's somebody else in there, is like, so you're stuck with this patient, you're not sure that you're doing the right thing. Sometimes you just have to step back and talk to somebody else and see if they have a fresh set of eyes that changes the way that patient is viewed. And it's really important to do that. And it's really important to do that for your entire career, is not to get boxed in on specific diagnoses when you go to see a patient. Because you will get burnt. You know, I'm sure you've been in that situation where you're just so sure that this is the way it is and that's the way it should be, and then somebody else walks in and goes, you know what, maybe it's not that way, maybe it's this way. And it changes the dynamic of the care. And that happens quite a bit if you allow yourself to get channeled into one thought process. So the other thing you have to do is you got to learn to keep an open mind when you're dealing with patients. And you have to allow for a shift in paradigm sometimes, because it's really important. Really important. I mean, you guys have some experience now. I mean, you know, what's your perception of critical care and how you address these patients? And what have you learned, like, what can you say you've learned through your experience that might help people that are less experienced?
My ultimate recommendation to everybody would be confident in what you know how to do, but if you don't know how to do something, don't be afraid to, under the supervision of somebody who can help you with that, attack that and make that weakness a strength, because ultimately you want to be as well-rounded as possible when addressing a patient that is critically ill. The second thing that I probably would impart is that the truly successful critical care physicians are ones that don't become flustered under circumstances that require clarity of thought, clarity of action, and ability to guide others that are your support staff in order to get things done appropriately. I think remembering the basics of establishing appropriate IV access, putting people on appropriate amounts of supplemental oxygen, getting vital signs, assessing the patient clinically, obtaining information historically, and keeping focus on airway, breath sounds, circulation, neurological deficit, environment, and exposing the patient to be addressed appropriately on your physical examination is paramount. And then just stick to your basics and, like you're saying, do things appropriately to maximize quality of life and quality of outcomes, utilizing the knowledge and physiology that you've gained through medical school and residency.
What about you?
Hey, you skipped me.
I was going to get to you last.
I'll go. Some of the things that you guys already said, and one thing I always think about is especially when you're by yourself in an ICU and the ER calls you down and all they've done is gotten a CBC on this patient. Your job is to really, like Dr. Siegel was saying, is think of all the things it could be, not what you think it is. If someone comes in with, you're like, oh, this is a COPD exacerbation, I'll just put them on some steroids and some oxygen, maybe BiPAP them. The next day, someone else will come in like, oh, did you look at this huge pneumonia on the left side? Like, it's important to always think what it could be and treat. Like he was saying, don't omit things because you don't think it is. You can always go back and take things off, but it's a lot harder to add things back the next day than it is to take them away. And the other thing I learned is don't be afraid to call people and wake them up. Because, we're only residents, so if you have someone with a cholangitis and the GI guy, you call the GI and he's like, oh, I'll take care of it in the morning, say, no, I think, it's appropriate for you to come in tonight. kind of make your case. Don't be timid. Make your case. So they're more likely to come in if you tell them what's going on and make your case, as opposed to I'm putting this consultant for you. What do you think? Like, make your case. Tell them what you want them to do, what you think they should do, and then let them decide.
Yeah, and I think just to piggyback a couple of things that Brian was talking about. First of all, always go look at your patient. Don't ever go by what anybody else is telling you or what the nurse is telling you. Always go look at your patient and always try to approach it with as if you don't know anything, like you're starting from scratch. Because if you get tunnel vision, you'll miss things. And another important thing I think I've learned is to always try to advocate for your patient. Because a lot of times the fact that they're so sick and they're on the ventilator and this and that, and the fact that there's a human being in there kind of gets lost, I think, a little bit. And so if you think that something is really the right thing to do for your patient, then advocate for them, obviously in a polite and professional manner, but really push for what you think is the right thing to do for them.
I mean, you got to look at patients like you got to take care of patients like you would take care of a family member, basically, is what it comes down to. You got to realize that you take care of somebody's mother or father or child or brother or sister, and you really have to understand that. And it's very easy to become inured to that fact, especially when you walk into a unit and you got tubes coming in and tubes coming out, and it's very easy to forget that there's people there. But you can't really forget that. And maybe we're up here and we joke a lot and everything.